Thank you. Such an honor to be here. I wish to personally thank Professor Schum for...
Let's wait a few minutes.
Oh, okay.
I'll
Oh, okay, okay. Very American, we just start, you know. We just start talking. Like Mr. Trump, you know, he just starts talking, you know.
So, has the new era started yet or not yet? I think if this is the first seminar you're attending in the new year, organized by the Office of Vice President Research, welcome. We'll be having many more symposium conferences as we start the new year, which will be an exciting year. So today we are really honored to have Professor Oster coming from the Tufts University. So he's the director of Tufts Comprehensive Epilepsy Program and also National Association of Epilepsy Centers, Level 4, director of the EEG Laboratory. We are very honored that he's in Hong Kong, and during his short time in Hong Kong, he's able to come and share his work with us at City University of Hong Kong. As many of you know, City University just started the new College of Biomedicine on the first day of the new year. It is only fitting that we are trying to bridge many more of our biomedical research with some of the best clinicians all around the world. And today we are very happy that we have Professor Oster sharing with us on a topic of using neuromodulation to treat intractable epilepsy. And this is an area that is important, but I guess many of us may be either working on more basic biomedical science problem or biomedical technology platforms. So hopefully there will be a lot of interactions and a lot of rooms for future collaborations. And we encourage you to continue to interact with Professor Oster after you've learned about his exciting research at his talk. So without further ado, please join me to welcome Professor Oster.
Thank you so much. What an honor to come. I personally want to thank Professor Schum and Professor Hay and Winnie for setting this up, and the university, local authorities, and Hong Kong to host me. This is an incredible, exciting time for me, and I look forward to our interaction and hopefully collaborations. I am very lucky to have patients that trust me to do what I do. Many of these patients certainly do not want to have this disease, and they've tried all of the standard therapies, and they are really disabled. And in our hospital, we have been very lucky to be supported in this endeavor to implement neuromodulation as a palliative treatment for epilepsy. So I will talk to you about that today. So this is some screenshots of our local venue, and Boston is a very beautiful city in the bottom left, and there's my flight path from Cathay Pacific on the upper right. In the middle is a patient who had very disabling seizures, who was seizure-free for several months, who was able to run our Boston Marathon. Unfortunately, the stress of that, she began to deteriorate somewhat, but she's actually doing pretty well. Some more screenshots of Boston, Beacon Hill, the skyline, the seaport, the public garden. It is a college town, lots of universities, lots of young people, lots of ideas, lots of excitement, lots of interaction between basic research, clinical research. We need each other. We need to talk to each other. we all have different vantage points and different points of view that with collaboration we can do more. Faneuil Hall, where the birthplace, the cradle of liberty, where the initial speeches were made, symbolizes, I believe, that collaboration. A shot of Harvard, MIT, and then from the Oculus of MIT, where we are. Let's see if I can use the laser pointer. Way up there, northeast corner. Sonny Lee is my brother, basically. We've known each other since 7th grade, 11 years old, and we've maintained friendship of all these years. He is an amazing individual, friend, brother, all those things, and we met at Boston Latin School, the first public school in the United States, founded in 1635. Harvard was founded 1 year later so that those graduating could go somewhere in 1636. So we are older, as sumus primi, we are first. So I've been a co-investigator on about 30 grant projects from private industry, but these are all given to the university, so I never had any conflicts of interest. I was very fortunate to be a collaborator in the Netter neurology series. Dr. Netter was a famous medical illustrator who dedicated his whole life to generating these beautiful figures. He was friends with a former chairman and boss, Dr. Harvey Royden Jones, who hired me to come into the Leahy Clinic system. He's passed away, so I'm very grateful for that collaboration, and I've co-authored several chapters on epilepsy and sleep disorders in that series, but again, no financial remuneration. So today, very American, I'm going to tell you what I'm going to talk about, then I'm going to talk about it, and then tell you what we talked about. Very, very American style, right? And I'll try to review the history and field of neuromodulation with an emphasis on what we call RNS, responsive neurostimulation. It's approved in the States. There are about 4,000 patients who are in their database for clinical receiving of the device. There's also VNS, vagal nerve stimulation, which is available in the States and in Europe. And so we'll talk about those modalities, but mainly the RNS, because it's a small computer that goes into the brain that analyzes your brain rhythms all the time. It's always there. So you can get a longitudinal recording and quantification of brain activity. The problem is you have to know where to put it. In a patient with epilepsy, it could be anywhere and everywhere. So you have to decide what your focus is, what you want to see, because it's a huge data set and the analysis is massive. So this is from the Netter book, which these are some of the standard drawings of Dr. Netter showing in the brain there are various cortical regions of, for example, leg, trunk, arm, face. These zones are located in the motor and sensory aspect, and when there's an electrical discharge in different parts of these postulations of the cortical zones, you get movement or sensory symptoms. So this was established by invasive recordings of the brain during surgery since the 1950s. Here's a map of the circuitry of an absence seizure, which I'll show you what these look like. So I want you to have a real sense of what a real seizure looks like. Many times animal researchers, they understand the concept, and we don't have the same concept of an animal seizure, but when we see our patients, but they actually are very similar. So I'll show you some humans with all the major seizure types so that you can really get a sense. So some cortical regions have interconnectivity with deeper regions and so forth. So in the evolution of our field, the thought was that you had to localize the specific damaged cortical zone, but many patients would fail surgery if you only focused on that element. In the last 10 to 15 years, we are now cognizant of the network, and there's a huge amount of basic science, receptor physiology, neurobiology that we don't understand yet of how this works and is modulated. We think it has to do with inflammatory peptides such as mTOR and various receptors, up and down regulation. GABA is thought to be the brake, the inhibition, and glutamate is thought to be the accelerant, but we have huge amounts of work to do. Of particular interest are these temporal lobe seizures, which occur at the base of the brain, basically, in the temporal lobes, where you can have hallucinations, funny odors. The uncus, or the uncinate fits, involve these gastric uprising sensations and psychic aura. The aura is the most valuable part of studying the localization for seizures, because the aura is the actual beginning of the electrical discharge that causes the patient to feel, sense, move, or behave in some way. If you can localize that zone, then you have an excellent idea of localizing the seizure onset zone and affecting potentially a cure. So a seizure is abnormal brain electrical rhythm, which sometimes they can be purely electrographic. You have no idea they're happening. Patient may simply have fewer ideas per minute, we think, just cannot respond, might maintain their posture even. This can happen all day and maybe lead to a misdiagnosis of attention deficit, for instance. So they may be subclinical. So let's take a look at one. So here's a patient who has been admitted to the epilepsy monitoring unit with these paroxysmal stiffening. This is a tonic seizure. The entire cortex is actually active, and we think that this is modulated by the frontal lobe, or the deep structures of the brain that interact with the frontal lobe. He has one side that is dystonic and one side that moves a little better, and it fluctuates. So there are ebbs and flows of pathways of inhibition and activation that you can see and infer just by looking at the video. So this is a tonic seizure that progresses and then terminates. I think this is the same one, if I'm not mistaken. Here is a patient that
I'm taking them. That's why I was telling them about it. I got more while I'm taking damn stuff, and they want to get me off of to try to make me have one.
affected.
They just put me back on the medicine if you
I'll
want to
stop
see me
talking so
have
the
this.
speech will change. Stop talking. He looks distressed. He's having some gastric aura, we say. And he's probably unaware. No one really knows. And he's having these extremity automatic movements. Many times the automatic movements neuroanatomically are ipsilateral, the same side of the seizure discharge, and that seizure discharge inhibits the basal ganglia, so you don't move on the other side. So this looks like this is a focal seizure on the right with impaired awareness that continues to proceed and evolve. And this is a patient that failed many medications who was hoping to have a localization for a surgical cure. And many patients who have this type of seizure, this is classic temporal lobe epilepsy. If it's on the right, in our institution and in others, there may be up to a 90 to 95% cure rate. The thinking is that the temporal lobe is somehow progressively damaged. We're not really sure, by excitotoxic injury or ischemic injury at birth. And then decades later, you have this phenomenology where it's not functioning. And the other side actually takes over. So these patients are able to support temporal lobectomy, particularly the non-dominant side. So these automatisms continue. The patient remains confused. But this is a patient who we never push them. They have no other option. It's really very sad. Quality of life sometimes can't drive, lose their independence, can't study, can't think. They take multiple medications. But a patient like this could have a surgical cure.
Well, I'm taking them.
Here's a patient that has a form of a genetic epilepsy called juvenile myoclonic epilepsy. In the morning has that brief muscle jerk with abnormalities of the entire EEG. In the past, we would think that these patients had too broad of an area of cortex, of course, to treat surgically, especially if medications failed. But the circuitry, the receptors, the gene is actually probably going to be well sequenced and available in the next 10 to 20 years, we hope. This is where basic science, neurophysiology, laboratory chemistry, This is where we can make a revolution in the field and give the patient potentially another gene that'll compete with the bad gene or replace it. A genetic therapy might cure this disease by splicing or in-splicing. I don't even know because I'm not a basic researcher. Dr. Hay would probably know better than me. You could essentially cure this patient with a molecular therapy. I want you to see some of the classic seizure types. So this one, I think, progresses to be a full-blown convulsion. This is very dramatic and dangerous. Patients that have any seizure type can progress to this. And this is where the mortality comes in. We have many patients that die of sudden unexplained death in epilepsy. So there's posturing as the frontal lobe is activated, and then there's a progression to clonic movements. The patient is unable to breathe during this and may have cardiovascular collapse and may do this out of sleep, may suffocate, may fall and have an accident. These have the highest morbidity and mortality and the final common electrical pathway for any seizure type. And this is what people think of when they hear the word seizure, is a convulsion. And after the seizure, the brain is exhausted metabolically, and it's thought that the excitotoxicity generated during the propagation of the seizure over time kindles or excites or induces other areas of the brain to become epileptogenic molecularly, so that seizures beget more seizures, so that the chance of having death, sudden explained collapse, injury is substantial. So I know you don't know a lot about EEG, but at the end it gets very suppressed as the metabolic supply of glucose is exhausted and eradicated. Now, here's another type of seizure that involves a more generalized circuit, but from deep in the brain. Many people actually outgrow this the earlier they get it. It's more common in women. We think it has to do with calcium channels. And she's just going to flutter her eyes and blink. She's going to be unconscious, but it's not very dramatic. So this patient may be in class in school, may not be getting the best grades, and she herself will not realize. There wasn't much that happened there. I'll show you again. She may not even realize that it happened. And in a classroom with a teacher with 30, 40 students, who's going to notice, right? So patients often are misdiagnosed as having attention deficit, and they don't always dramatically flutter the eyes. They may simply have the alteration of awareness. And they're brief. They can happen many times a day. There are many mimickers, such as this one, which is a sleep disorder. This is an infant during my fellowship. This is a long time ago, where the video is very hard to see. I apologize. But this patient's going to go into slow wave sleep and have a dramatic, prolonged event, which is a parasomnia. So parasomnias were thought to be related to epilepsy. In the brain, between the cortex and the deep structures, there are programs of activity, how to move, how to play the piano, how to play the violin, how to walk, how to do various motor activity that get activated. So we think that these get released. So this patient thrashes about. The audio is quite dramatic, but it's not necessary to hear. But this is thought to be a release phenomenon of the cortical and thalamocortical circuitry resulting in this behavior. This is not volitional. This patient really is still in sleep, although the EEG is dislodged in this case. So these are very amazing observations in humans. And so we have 2 patients every week that come in for this type of activity. Here's a patient that had
What else do you feel right
status
now?
epilepticus.
Just a spasm of the trunk.
Arterial venous malformation in the
Your
motor
leg?
cortex.
Do you have numbness in the hand or anywhere
And
else?
his seizures would start with this pulsatile sense of
like
the
that.
abdomen. This is from a published case
This
that I
is
put
in the
online
right
of
motor
trochal
strip
status epilepticus
in the
that
perfect area.
we localized and
And it stops very abruptly.
ultimately stopped with
Starts as-
medications, but some patients require surgery. But surgery in the motor area might cause paralysis, so we tend not to do that. A patient like this would be a perfect candidate for neuromodulation. Neuromodulation, we could put the computer there. We didn't in this case. Not resect, not cause a neurological deficit, but modulate this over time. This is a patient that didn't have seizures at all. That sometimes we have patients with stress and psychogenic seizures. So this is a young person who has this body trembling, which is not producing anything but muscle artifact, and then This is non-physiologic. He's awake and responsive, but having bilateral movements. So by our testing, we diagnosed him with a stress disorder. This is not a seizure, but he was treated for 10 years as if he had a seizure, and that's why the medicines were failing. Some patients have syncope, where they have hypoperfusion, where the blood flow to the brain will cause seizure-like movements. So here's someone that's going to hyperventilate and decrease blood flow back to the heart and to the brain, called decrease their venous return after they hyperventilate. And the patient is going to get lightheaded because they're going to lose their blood flow. It's a young, healthy college student. I think you can write. And then syncope, because they can't maintain the muscle tone. And then have these abnormal movements, which are not seizure. This is from hypoperfusion of the cortex bilaterally. Seizure-like. We also get patients that sometimes, this is a patient who was, I was told, had a seizure disorder. We needed to offer surgery or a device. She's behind this television in our clinic. And if you look at the bottom channel, this is the EKG, the heart. There are different morphologies of it, so there's different interventricular conduction delays. It's not a standard. But then the regular heart rhythm stops. The brain waves actually persist for a while. The patient is somewhat distressed. We can watch this again. I had this published online as a series of when the heart stops. So there's no organized cardiac output, but yet the brain cortical rhythms persist. I know you don't know anything about EEG, but the electrocardiogram persists for about 23 seconds, and then, because there's no heart rhythm, then the patient has no electrocortical rhythm and goes into this slow wave and attenuated pattern. And then the heart starts up again, the patient becomes alert. So we have to be very important that what we're looking at in these patients are not cardiac, that they actually are cortical localizations, because the anatomy and treatment will depend on it. Worldwide, these are the numbers for the epidemiologic standing of the disease. We know there are about 3 to 5 million of patients, if you Google, or not, if you search on the web, how much epilepsy there is in the United States. So there are about 50 million cases. We're up to 3 million, not 2 million. This is a slide I put together about 5 years ago. And the rates and prevalence throughout different countries and regions is pretty similar. The traumatic brain injury, where you have young people and then college students with cortical damage, is that dark area. And then as we get older, cerebrovascular disease disrupts cortical anatomy. And in the tropics with various infections, there are more cortical regions. But patients that have temporal lobe, about 60 to 80% of them will have this classic lesion, which develops over time, over decades. This area of the brain, when in brain development, it's called the Summers sector, is very sensitive to ischemia when in the birth process. It's thought that that ischemic injury sets up progressive scarring over time, where there might be some loss of structural finding and then a signal change, and ultimately loss of the lamination of the hippocampus with filling in of ex-vacuole fluid because it's no longer there. These patients particularly have a very high rate of surgical cure if you can identify them. So that's why I wanted to highlight that finding. In our centers throughout our Tufts and Greater Boston, and those that are designated with an epilepsy certification, we have MRI at 1.53 and now 7 Tesla. And we can sharpen up the cortex with these external coils to show a subtle area of thickening, which may be missed previously as a non-lesional case. So this may open up a cure for a patient to find the subtle area that's not anatomically appropriate to affect a cure. Here's one that was pretty obvious if you read these. This was mesial temporal sclerosis. This was read as a normal scan for 10 years. This patient we operated on and he was cured. We have metabolic imaging where we can give technetium or Neurolite and we look for hypometabolism. So the more blue there is, and these are somewhat subjective by eye, you really need quantitation and voxel per voxel differential analysis with the computer sometimes to see it subtly. But this is an 18 FDG PET showing left temporal hypometabolism in this patient. And this is another example of an external coil. So in the case of truncal epilepsy, we localize some of these by Syscom, where we subtract an ictal recording. Patient sits in the monitoring unit in the hospital, like I showed you, and within 30 seconds of the onset of the seizure, has to be, when you have the isotope there, the personnel has to be that you inject it, and it gets taken up by those cells that are metabolically active, and you can make these maps, and it correlated with this area of gliosis. So this is the motor strip, this is the sensory strip, this is the omega gyrus where the hand function is, and the trunk is in the midline. And then there are patients with brain tumors or lesions who may have creatine, choline, and NAA levels measured depending on how aerobic or anaerobic metabolism is. And what's interesting, if you make maps of EEG activity and metabolic activity, there are networks that are even distal from this very necrotic lesion that you can see that are impacted. What is the neurobiology of that? That's where we need research. That's where we need to know in bench laboratory preclinical data what actually happens in those systems. This is a case of a patient who had musicogenic epilepsy. Every time she heard tonal music, she would have a seizure. She lived her life pretty normally until whatever music happened, it would affect her. So we mapped out with metabolic imaging in the anterior temporal lobe. This is a sagittal sideways view of the brain. And it's been about 15 years. Now she's seizure-free, but metabolic imaging drove the localization of the cure in our center. Many other centers didn't want to do anything because there was always another medicine to try. And she was a non-lesional case. The patient herself was uncomfortable about having a normal appearing region of the brain resected, but she's been seizure-free now for about 15 years, and we did that scan about 15 years ago. Subtle lesions, sometimes just a different sequence. This is the lesion here that was also missed on this patient with frontal lobe epilepsy. The problem is that these patients on EEG on the surface may have, this is this patient, had nothing during the seizure, and this is all muscle artifact. This is an electrode placed into that lesion at the time of surgery where these are abnormal volleys of discharges. This patient here had a normal or non-localizing EEG and had discharges that, when we put electrodes on the brain, came from this region. This patient, the supramarginal ramus of the motor area division is missing. This should go all the way to the cortex. And this patient too, you could see the very discrete onset. The surface recording on EEG didn't show anything. You need 6 square or 6 cubic centimeters of synchronous activity on the surface, which is not filtered or attenuated by blood, brain, meninges, fat. So these surface recordings are too unreliable other than placing electrodes directly on the area, but you have to watch the videos, you have to have a hypothesis. This patient had seizures, this one here in particular, had seizures that started in the focal motor area of the hand. And we found this lesion here at the bottom of the omega gyrus, who ultimately, right here, who ultimately had this activity recorded from the anatomically appropriate area just by looking at the videos. We never would have found it. Now, this patient, upon pathology, had some pathology that was yet unknown. It was gliosis, nonspecific. Now, in animals and other systems, is it widespread? It happens to be more focal there. When you operate there and remove, do you unleash other areas that have a different threshold? We don't know. This patient has been cured for about I want to say about 20 years. This is one of my first patients 20 years ago. We can map out these tracks, these beautiful connections with free surfer and with looking at direction of diffusion of water molecules in compact bundles. So this is the Broca's language center and the Wernicke, the spoken language in the frontal lobe and the posterior association word sensing area, and the arcuate fasciculus. So we can play around with what we want to look at on functional MRI. How packed are those fiber bundles? And there is a differential connectivity to make these beautiful maps. So here's a patient. We didn't quite know what we were looking at, but there's a difference in their connectivity from side to side. So you can find subtle differences. This is where AI, the computer analyzing volumes of amazing amounts of human voxelation of these that can find the subtle difference. Can a radiologist in an academic center who doesn't do research with 50, 60 scans a day find a subtle lesion? We don't do these sequences routinely. They're probably not. So there are huge amounts of patients that probably have treatable, provable pathologies that we just don't know about. During COVID, my team was looking at, we have very little manpower. We were trying to see in patients that didn't have a lesion, didn't have a focal finding on their EEG, is there actually a difference in patients that come in confused with what we call an encephalopathy in their localization? We're still doing this work, but this is how these computers these days can work. They can analyze the frequencies of different voxels and even plot frequency maps of different frequencies on neuroimaging. It's quite an amazing field, and we're still doing our analysis of these patients. So epilepsy is a network, and the challenge is now to find the network. So we know patients that have continuous seizures. Here's a 9-year-old. When I was a fellow, you could see the thalamocortical dysfunction that happens over time. There is a neuroanatomical localization of change in the cytoskeleton, the water content, the compactness of the bundles of the fibers. We don't even know. And patients that came to the epilepsy monitoring unit, I published this series of patients that came in, and they would come Monday through Friday. We would take them off their medications, and they would have lots of seizures. And then, because a lot of them came from out of the area, they would have their MRI for convenience on the last day and then go home. Some of these patients had lesions in the splenium, which connects both temporal lobes, because we think that the overwhelming volume of electrical discharges caused breakdown of the lamination of the myelin and the cytoskeleton, causing the water molecules within those fibers to become more random. And you can see them in the diffusion-weighted imaging, ADC, FAA maps, which I don't show. So you can find how that directionality of the dynamic change of the movement of the water molecule and disruption of the lamination of the fibers can change over time, and then over time it healed. I was called on these patients, they had a brain to a butterfly glioma. No, they just had a bunch of seizures. And the seizure activity caused ultrastructural change in the connecting pathways. Here's a patient who had seizures on the orthopedic surface, which were unidentified. And until we put an EEG on, we found that she was in status, and you can have meningeal and other gross changes. But when you treat her with an old-fashioned drug, someone without epilepsy, the brain normalized within 3 months. This is somebody that had a brain hemorrhage. Don't show that. Over time, we published this case of an adult who had a normal brain who has mesial temporal sclerosis develop in about 40 months, and pathetically, or with feelings of empathy and sympathy. This is a patient who didn't take their meds. Why? Well, their memory was so poor because of this lesion that they couldn't remember to set a device that would help them remember to take their medicine. So this poor patient had seizures despite medical therapy and a lesion. He could be cured with surgery. Here's a patient that had a resection at another medical center who failed the resection, but we identified on bold signaling areas of where the seizures really started. They started outside the bed of the resection. Then we tried to prevent that outcome in our center. We really don't want to have a failed resection. But you cannot resect in this area, this is the language here, this is visual motor processing, this is a perfect place for neuromodulation, which is why I show this at this point. So this is that case I showed you that was resected that had that very focal change in the hand area. And this is the area at the bottom of the omega gyrus, which controls the hand. This patient had dyslamination of the cortex and did not have the typical 6-layered, which I should show a normal one, and had the very discrete seizure onset when you put electrodes on that place. And we can find patients that have dementias, that have amyloid, tau protein. We discovered this. This is a patient, early 2000s, that this is the hippocampus, which is either seizing, about to seize, or having these very aberrant discharges. This patient was functioning basically as an amnestic patient and was always having seizures. Was that causing the amyloid deposition, or did the patient have amyloid deposition? This is the effect. What is the neurobiology of this? And this is now very accepted, and my mentor, Dr. Cole, who I trained with him, and Ahmad was our fellow, and I used to work with some of these. So they published this in the last few years, but I had that case like 20 years ago, not to be arrogant, but we know that subclinical seizure activity occurs in different parts of the brain. You can't see it on the surface. Despite having 30 seizure drugs available in the United States of America, there are patients that do not respond to them, about a third of them. And then there are side effects of medications. And the epilepsy patient has such a disease where they have embarrassment, impairment, loss of liberty, loss of freedom, poor cognition, because overall on these sedating medications that do not work, they are slowed down, they have trouble paying attention. A lot of them are overweight, have metabolic syndrome, have sleep apnea, which makes seizure worse. This patient has a trajectory of a very significantly poor outlook over time from a psychosocial point of view, in addition to the underlying neurobiology. So we feel we need to advocate for these patients and do all we can. The challenge is to identify the epileptic zone in the network as early and comprehensively as possible to prevent the kindling, the abnormal development of further distal areas that might become epileptic too. So electrical stimulation has been known since antiquity. And these are some of the references. I borrowed this from Fisher from California. And the idea is that electricity and disease and natural philosophy was harnessed with these contraptions, as you can see, in the 1800s to harness the power of electricity. But Jasper and Penfield in Canada, they mapped out in this manner with probes onto the brain with very careful, controlled electrical stimulation to give us the homunculus, the map of the cortical zones of the face, eyes, hand, thumb, leg. So they were groundbreaking, and they intraoperatively are really the basis of what we do at our medical center at Tufts. So we have cases where we map out where these particular functional zones are so that we can find the abnormal cortical zones and treat them. So let me just show you some of that. So we know a lot of these areas have functional problems, and some of this work is from my mentors and affiliated staff that I used to work with. But 1929 is when EEG was developed by Dr. Berger. And with these RNS devices, we can now put them on the cortex of the brain and look at compressed EEG. The device is approved only to have 2 electrode arrays. However, we often investigate these patients with numerous arrays of intracranial electrodes to determine where the seizures are coming from. And this is what you might see. This is not a typical EEG from the surface. Here's someone that has seizures that start on one pair of electrodes and propagates to the other. So like the satellite imaging on the internet, where you can look at the continent and then go down to the very address, that's what this intracranial investigation will do, ultimately allowing us to put a computer in the skull with 2 electrode arrays, sometimes a depth, into the zone of interest. So this records brain activity, stores it in a tablet. Every day there's a data set that's recorded with arbitrarily defined metrics. We have long episodes, which we just arbitrarily count greater than 30 or 20 seconds, depending on the brain region. We have saturations of channels. And then we have discharges, which we don't know what it is. It's a huge data set. A lot of it might not even be seizure activity. We have to quantify it, though. So this is the screens we look at in the patient list. This is the kind of EEG data we can see over time. So each one of these horizontals is a day, potentially, or a month, depending on what time course. And we have a library of the ECOG. It can store 15 minutes of electrocorticography. So the patients have a computer and a wand, I'll show you, to upload it to the cloud, to the data cloud, where a team of engineers will manipulate and analyze this data to tell me and the team whether or not they're having seizures. We have about 40 of these patients now with this device. It is a huge number of patients, a huge amount of data. And the biomarkers tend to be these longer episodes with some amplitude change or these saturations. And here's a treatment paradigm. I just want you to get the flavor before we dive into some of the actual recordings. So this is arbitrary. So if temporal lobe seizures last a long time, so we want to know if there are dysrhythmic groups of equations, mathematical models of these channels longer than 30 seconds. If it's outside the temporal lobe, they tend to be shorter because there's more interneurons that might dampen down the seizure, we think. There's more GABA-related attenuation. But we don't know what the patient reports necessarily. So there are some patients that have a lot of activity. We started drugged and they have fewer. Here might just be they didn't upload and we don't have the data, we don't know. And then they tape, so the patients are on 4 or 5 drugs, they often come off their drugs and they have subclinical discharges which may not even be correlate. But these are long episodes. These might be electrographic seizures without any motor manifestations. Saturations of channels are more reliable, these big tonic-clonic seizures, like the one with that kid that I showed you that was convulsing and might not be able to breathe. So the paradigm, the mathematics, the engineers are able to identify these quite reliably. These are more of the biomarker of that. And it's amazing, the patients at night, how many they have this that never report it. A caretaker, even the most diligent one, cannot be with the patient 24 hours a day. This might actually keep them safe if we could actually generate some treatment based on it. So here's what a long episode and a saturation looks like. I think you have that idea. And here's a patient that really just has 600, 800, sometimes 1,000. We have patients that have 4,000 discharges a day. What does it mean? Here's one with 5,000. Then we started treatment. This is a patient that has cyclical variations, I think because they don't upload, but they may actually have ultradian rhythms, like a hibernation. There's this ultradian rhythmical network that happens in these patients, which you can see just by grossly looking at these slides. Neurobiologically, what does it mean? No one really knows. And this is what some of the programming parameters look like. We can make it positive, negative, use even the computer as an electrode and different parameters. But let me show you what we actually do. This is actually in our operating room during some of these procedures. So these patients who are so affected have failed numerous medications. They've gone to numerous physicians, numerous treatments. They are desperate. And many of these you work with over time, they don't trust you either because all these other centers have tried their best. They're eminent science and eminent scientists and eminent clinicians, and they're still having seizures. So it takes months, sometimes years, for these patients to trust us, but when they do, we bring them intraoperatively to have slotted cranial placement with good Surgiseal so that we can put the device in and they don't get meningitis or infections. These stay up to 2 weeks. So this is an actual bed. These are the wires that poke through the flap. And here's one pair of, I guess there is a name for that, surgical snap. So this is the actual slotted craniotomy that gets placed. And many times we're in the OR for different things. Here's one we happen to be with the vascular team. We have the EEG apparatus has to be out of the way of the surgical field, but we have to know what we're monitoring. Let's see, I forgot what we... So in real time, we have to be there, we have to be looking at it, we have to know that our electrodes are the fidelity of them, they're working, they're not artifacts, they're not influenced by the anesthesia, the electrical interference. So here's the placement of a probe. I don't know if this projects well. So there's an electrode. This is an arm that is the electrode array he's placing through a cannula. Many centers we use a robot. They're about $500,000 minimum, and are they any better than a surgeon that knows how to place them carefully? We don't know, so we don't have a robot currently at our center. We pull it out. We have a like this. Very good surgical team. This is Dr. Daniel of epilepsy surgery. Personally places these generally with me in the OR. And this is our navigation system, which is quite nice. And we can see in real time by just having a magnetic probe on the patient where the cannula of that electrode is to generate these 3D images. So where is this probe? It's going to this temporal lobe. So we can map out exquisitely to the millimeter of where it actually is, so that we know that we're sampling what might be the hippocampus and the temporal lobe in the depth. We also put strips on the outer surface of where our hypothesis is based on looking at those videos. Here's another one. This is a brain tumor case. So we've started at looking at the electrical margins. This is a patient with probably a necrotic tumor that may not do well. But the idea was he already had a resection and was having lots of seizures, which we couldn't tell from the EEG where that was. And so the surgeon was going to electrically clean up the margins that were most irritable. And he did somewhat well. He wasn't seizure-free. But instead of having 5 or 10 seizures a week, he had 1 a month, something like this. Yes? Please, Oster. The seizure, yes. Yeah, we have to have a hypothesis. Ah. Like this. So here's an electrical probe, very crude, bipolar. We often give stimulation before we put the electrode. So here we think we're trying to produce after discharges, abnormal chaotic rhythms. Or sometimes if you deliver the current, it might actually suppress it. And that is what we don't know. There's no atlas, there's no roadmap, there is no well-accepted set of landmarks. And the brain, it's really quite amazing, can reorganize over time. So patients that have chronic pathologies adapt. So what you might find in one cortical region in one patient might not translate to the same region in another patient. It's very, very not reproducible from patient to patient. So let me show you the video of how we produced that stimulation. I had a feeling someone was going to ask. So this is a real stimulation to see if the patient is doing mathematics in the background. And the patient is actually extubated and under good pain control. I'll show you the video of him under the curtain while we do this on the next slide, but let me just play it again because it's quick. He's doing mathematics in the background.
1 + 7 + 9 - 3.
I think this is a patient that worked in finance who didn't want to have an impairment after epilepsy surgery. And this is in the dominant hemisphere near the speech, language, and mathematic processing regions. So we wanted to make sure that if we found a focus and we stimulated it, we would find after discharges, or we would find speech arrest, or we would find an impairment. So we spend hours sometimes doing this. It's very crude. We know we can go up to 12 milliamps and 50, 60 hertz before we cause brain damage. We often really don't go up that high. We go to a couple of milliamps, 2, 3, 4, but we like to do the 50, 60 hertz stimulation because sometimes that's what it takes to produce a chaotic rhythm in that area. And then does it spread out of that area? Or does it inhibit other areas? So we have to spend a lot of time mapping this out in the OR. Some patients have a grid in or electrode array at the bedside. We can pass current through it over multiple days and test them while they're in our epilepsy monitoring unit. So we do that too in some patients. But here's a patient that really, we knew sort of where the seizures were, who already come in for electrical array placement in this area. We stimulated at the bedside and we proved that it was safe, but we always do it again in real time to make sure that we know where we are. So this is a duplicate of that. And then, so if you look at the screen, here he is under the curtain. He's not intubated anymore. He was intubated. This is the anesthesia cart. You can watch him talk and respond as the stimulation occurs. So we do this about once a month at our center. We have a case. He's blinking, he's awake, he's extubated. We're showing him green cards here. This is somewhere in the posterior aspect of the dominant temporal lobe, the language processing area. We want to make sure that if we operate there, we avoid those eloquent areas. So this is really, and so some patients, this is what we see. If we put an electrode array, if our hypothesis is correct,
I mean, we have
see
this in the
very
PBMS, but I just
compressed
want to show the
chaotic
slide.
discharge. This is from the responsive neurostimulator tablet itself. This is a recent patient who our hypothesis was that the electrical cortical irritability was in this region. And without doing anything more than placing electrode strips over those zones, we were able to prove that this was active. This was somewhere in the frontal lobe, so it didn't really matter for functional mapping. The patient didn't have to be awake. We were away from the motor strip. We were away from the somatosensory areas. We weren't in the visual cortex. So we were able to localize the pathology just by doing that. So here's an actual what happens during a resection. Now, why is this more white? So some patients who have subclinical seizures, the blood vessels get engorged. Other patients are hypotensive so that the surgeon can see the field. This patient, I think, was hypotensive. They had to give dopamine and also epinephrine, so the vessels are clamped. So the cortex looks more white. But this is a short clip of actually a resection being done with electrocautery at our center. So it's very, very time consuming. And so like under the microscope, you don't see the beautiful 6 layers of cortex. And this is more crude. This is much more crude. But the biology of the tissue is essential to understanding of when, where, how, why, what extent we should do. This is what happens in the office these days. So this is a patient who had seizures that start in both temporal lobes. My hypothesis was that he had seizures for 20 years and had kindled the other side. He's someone that almost went for a temporal lobectomy at another hospital, but was afraid that he was going to be amnestic, and he was actually correct. We put the neurostimulator in both temporal lobes and sent him home just to keep it on to record, not even to treat, because we wanted to prove the localization of his seizure disorder. And if he was exclusively a non-dominant onset and propagated to the dominant side, he might actually be a cure. Now, we know many of those patients that have bilateral network disease are very much at risk of having neurocognitive dysfunction, inability to form memory. So we additionally recorded him for about a year. Then we did a water test to put the side of resection to sleep and see if he could remember. And he couldn't remember, but he had had a lot of seizures during that year. He was very disappointed. He's from, I think, Fuzhou. And he came to Boston, and he got divorced after 20 years of having seizures. It's very, very sad. So finally, he let me turn it on. So in the last 6 months, we've had some seizure reduction. He's had over 200 seizures, all starting on the right. They do propagate to the left. So my hope is that maybe an area of our research is that by suppressing the periictal propagation to the other network, that could he potentially support a temporal lobectomy and a cure and be like a 90-95% cure? No, we don't know. Or is he going to need palliation from the device? Now, we have no idea how the neurostimulator that's implanted over time chronically works, but it seems to cause significant seizure reduction over time by an unknown mechanism, whether it has to do with neuroinflammatory moieties, upregulation of GABA. There are some centers now that are doing interneuron transplants into temporal lobes that are stem cells that produce the GABA to do it. We have no idea. So in California, there are researchers that are putting those stem cells in that just simply produce GABA, inject crudely into the temporal lobe. We're not doing that, but that's part of a trial. But in the office, this is what it looks like. So this patient, about a year before, had
This
his
is
implant.
modern
So this
epilepsy
is one of our
clinic
exam
at
rooms.
Tufts Medical Center. We have patients that come in after having a device placed called NeuroPace, or responsive neurostimulation, targeted exactly where seizures start for treating the epileptic network. Our patient agreed to highlight video of how we do this today, and we're very honored
He
and
looks
grateful
pretty good. This is a year
for
ago.
patients like
He
him.
has a computer in his
So there's a
skull.
tablet and a computer that allows us to interface with the device, which you can't actually see, it's implanted. And patients allow us to communicate it with by this wand, which he'll put up onto
He
the
has a
skull.
computer too at home. He uploads a
And
couple of times a
we
week
can
for us.
interrogate the device and communicate with it in this fashion in our ambulatory outpatient. Our patient has had 20 years of unremitting seizures and has failed medications, so it was his hope that we would verify the site of origin and have surgery or stimulation or a combination of such therapies. The device allows us to see activity longitudinally over time with daily histograms of activities which we can filter in terms of what the data
Goes to a
can be
cloud.
divided up into long
Engineers
and
look at
short
it every day.
episodes and saturations as follows. So for example, if we filter the data to look at long episodes that are collections of interictal discharges that are and activity that the computer is able to sense it's more than 30 seconds or 20 seconds, you can see there are different periods of times where he has those, as well as when there are channel saturations, where the activity on the implanted channels are very significantly saturating the channels. So we can get a good day-to-day look at the brain like an ILR, an implanted loop monitor of the heart. This is essentially an implanted loop monitor of the brain.
This is like a
We can
pacemaker
review
from 60
live
years ago. In the
electrocorticography.
brain. This is live brainwave
And
activity.
these are in the vicinity of the implanted electrodes. And in our patient here, we can see actually
So
bilateral
he is active.
discharges
These
at this
shouldn't
point.
be there. So we're only recently started turning on
And
the stimulation to treat that. 'cause he
Programming,
didn't
which we've
want to
already
do that. So we
done
respect his
today,
autonomy.
we have a number of
autonomy,
stimulation
autonomy.
parameters, and we can test
Autonomy.
various ones and see if the patient has any after discharges or feels them or doesn't feel them to guide further therapy.
So he has no idea these
So
are
I'm going
happening. You know,
to
he
give him
lives
some test stimulations
every
of
day.
these last.
So these bitemporal
Settings.
cases, we want to make sure there's no neuroinflammatory diagnosis. We look
And
for receptor antibodies. We
I'll do
often
this
do
a
a
couple
spinal
of
tap and make
times.
sure there's no tumors,
see if
something
there's
else that's
interictal
causing
background.
the temporal lobes of the brain to be
Not
irritable.
seeing
He had all that, but so he walks around
any
with this
actual seizure activity, which
computer,
is good.
so
But
that
are
we can
seeing
figure out the
some
next
activity
plan of
bilaterally.
treatment. And in the
We
office,
will see
I
how he does.
see
with
what
the
he can tolerate, sense,
Patients,
feel.
they do their uploads a
so
couple
that
of
we
times a
can
week so
make an
that
adjustment
the
every 3
engineers
months. We think
who
it
look
takes
at the
about
data
3 months
cloud
for the system to adapt
can
for
monitor
there to be a downregulation.
progress
We don't even know
and look for
what receptors are working or not. But in the
any-
last bit of time, I just want to
any
show you a
outcomes.
flavor of some of the cases that we've had. So let's just see. For example, we had pregnant women that we had one lady that was on 5 drugs that had the implanted device placed that ended up on 1 drug, who gave birth, who was seizure-free for a year after we got the setting programmed over a year or 2, the device program, who's on 1 drug, the device, and is driving. If we look at maps, at the time of this analysis, I gave this talk at our medical center at the end of October. We had 27 patients. Now we have about 38, I want to say, including the ones in the other center. We know that these are all comers. Almost 90% have a reduction in those groups of discharges, but 56% actually are seizure-free after 2 years, which is, we have no idea why. We don't know if it's placebo effect. We need to study it more. I've been there 10 years. The technology was approved in 2013. Our first implant was in 2016. So some of these patients have been implanted since then. Not a long, and we know based on time, how much reduction occurs by time. There are 4,500 patients in the United States that have a computer like this, and the average responder rate at an institution is 74 and 34. We're almost 90 and 56. The thought is that many patients, many centers need to do stereo EEG to put electrodes through the brain to get these pathways that propagate the discharge. So this is very fashionable and embedded in the culture to buy a robot and do that. Whereas at our centers and centers like we believe epilepsy is mainly a cortical disease. So we know, our philosophy is that by analyzing the clinical attributes, looking at those videos, having the patients have a very comprehensive and thorough analysis of how the seizures start, that we find the cortical zone. We think that may be responsible for our success, but we don't know. And we need to study the tissue that comes of this electrically to find out the genetics, the array of peptides and so on, and biochemistry. This is where collaboration, for example, with you would be invaluable to learn what happens over time. These are just some of our patients where the leads are, the outcome. Many are seizure-free, and we can verify it by seeing that there are no discharges. So here's someone that does an upload. Every time he's doing well, he doesn't do his uploads, and then he has a seizure, comes back to the emergency room, does his uploads again. So this patient has that memory problem. And then he also has freedom for the first time of not having seizures, and then he gets, he cancels his follow-up appointment, and he doesn't do the next step up on the adjustment. So it's actually kind of neat. Here's someone that had 2 resections that failed, who had gliosis around one of the regions, but had discharges in the language area, who has 1,000 discharges a day. We ultimately made him seizure-free. He was able to sail for epilepsy. This is our chairman of neuroscience, past chair, who is also a sailor, and he empowers a lot of these patients to get on a boat and be out in the open. This is the marathon runner who has a malrotated hippocampus on one side, but had this massive array of discharges, 2,000 a day. After we turned on DBS, we put DBS leads in her. She had a drop-off of discharges and a surgical cure with neuromodulation, and it's been durable. So here's one of our pregnant patients who was part of a larger register that I alluded to, who had a lot of seizure activity during pregnancy that wasn't seizure, it was subclinical, who managed to get through a pregnancy safely. And this is what her corticogram looked like over time. We were able to be part of a larger series and publish that data. There were only 11 patients who had this device during pregnancy at the time. We've proved by observation patients that vaping of substances, when they have these very malignant long episodes. This patient ultimately passed away, but not from SUDEP. We were able to see that he died of an overdose and not of a seizure with the implanted device. This is what EEG activity looks like. So there's different chaotic regions. You can tell with mathematical analysis, AI, engineering, bioengineering, what is driving what. I can't, as a doctor that's spending 30 minutes with the patient, do all that. I need a team of scientists and of researchers to help us analyze this massive deluge day-to-day count of quantitation of discharges. So the mathematicians were able to determine which region was driving. And so we programmed the device in this patient who had an electrodecremental pattern to find the right spot, who's doing well now. So this is how we use this data. Patients that have lesions in the occipital lobe, we don't want to make them blind or have a visual field deficit. So we published a series of patients who no surgeon would ever operate on because they have a big field deficit, who did well with very low level of stimulation with arrays like this. So all of this is really amenable to research, development, determining what the neurochemistry is. This is a case that the patient had a complication in our center. We had the patient in the OR, and then he hemorrhaged into the ictal zone, and stopped having seizures. We don't encourage the surgeons to cause a hemorrhage, but this is a known complication. This patient hemorrhaged into that ictal zone, but the other side, which we also suspected was epileptic, a year or two later became epileptic. We let the computer stay on, but we didn't stimulate anything. So we are learning about the evolutionary nature of these networks, and we have no idea what the biology of it is. This is where partnering with research is so important. Now, the vagal nerve stimulation is not in the brain. It monitors heart rate. It simply delivers therapy over time. Unlike this computer, which is always on, which is analyzing, which is directly on the seizure foci. So there are numerous articles, which I could do another hour to talk to you about the literature, which I thought you'd get a better, more understanding of actually seeing what I showed you rather than these very dry slides, which show safety, efficacy, and neurostimulation is reversible. You don't cut anything. We try not to have patients have hemorrhages and complications, but in that case that happened, the patient was nearly seizure-free for 2 years, because they hemorrhaged into the ictal zone. There are no known chronic stimulation side effects, although in the trial, in the Sante trial, there was some depression. And the company and the neurophysiologists and the engineers now can tell you from a database of patients what the outcome is going to be based on the region and what programming we should put and over what time and what step up and step down. If we know this from like a cookbook for over a 2-year period with these 4,500 patients nationwide. So we allied with the company and their regional science liaisons to get these charts and neuropsychological testing, naming, memory improves. If you make the brain not seize, it can be busy doing cognitive tasks, especially not on these medicines. They have all these quality of life improvements. And sudden and unexplained death decreases, and medications work. So let me just jump to there are circadian effects, patients that have seizures now at night rather than during the day. I know I'm going very fast. We had a patient have seizures with change to daylight savings time. So now we're analyzing all of our cases before and after time changes. We figured we'd use some temporal age control, match temporal cases, and even with those 4 cases, the amount of data to analyze is huge. It's too big for me, so we're very slow. This is where we need an ally in biomedical engineering. So we managed to get that one case published. We have some cases that now, in COVID, so I had a hard time getting this published. And we had patients with the stimulation device implanted that simply by having them come to one of those office visits, I saw slight increases of counts. And in retrospect, with the red arrow, this is where they were COVID positive, but a lot of them had subclinical discharges increased beforehand. So we know COVID, and we studied with the vaccines also, that there is subclinical discharge activity. What it means, we don't know. But it's a nice tool to quantificate actual volleys of biomarkers which might be seizures, of which we haven't had before. So this is the patient that died of SUDEP. This is a neuroanatomical study. I just want to show you some highlights. I know I'm going fast. Hold on. So some patients, after we implant them, they don't have seizures for like a year. So there's a post-implant effect. I'm still writing this up. I presented this at the American Epilepsy Society, but because I see patients all day and I don't have enough time, there are some outliers, 2 or 3 standard deviations on what you'd expect with the patient's seizure frequency. So there is an implant effect, whether it's the anesthesia or the brain knowing it's being watched, we have no idea. But there is a certain percentage, we have 4 or 5 out of these 35, that did not have their seizure habitual frequency resume post-implant that we can't explain. And then we had several cases that had surgeries, multiple resections at other medical centers, that we found the areas posterior to the resection cavity, usually in the processing areas, post-language. These patients did pretty well, so I presented that in Rome in the European meeting last September, and we still haven't written it up because, again, there's no time. And with good functional outcomes. This is a patient with an AVM, no treatment. We put this right over it. This patient was helicoptered, flown several times a year, a $50,000 bill, to an ER. Now he's only had a couple of ER admissions. He's not seizure-free, but he's not in status epilepticus, not continuous seizures in his sleep, doing much better. And then we have a patient that that had meningo-inflammatory encephalitis around this time last year, who had bihippocampal, bitemporal lobe signal changes from the seizures that was not able to be extubated, had gone back into status every time we weaned the medication. But we had implanted her bilaterally as a heroic means, and she emerged after we got to 3 microcoulombs in each temporal lobe, bringing the discharges down to 2 to 4 hertz. And she's now home with her child, is somewhat amnestic, but is out of the hospital, would not have recovered without it, and in a bilateral new onset refractory epilepsy case from meningo-inflammatory disease. We think we made a difference. We can't prove it. This is a palliative role for this treatment. What's going on at the molecular level? Again, nobody knows. But this slide is the basis for deep brain stimulation. So some cases have too diffuse of an area that you would stimulate. The battery would die. You would feel that you don't get enough cortical zone. So if you look at the different regions of the thalamus, this is the pulvinar, which gets mainly posterior quadrant inputs from the occipital lobes, CM, which is centromedianum, these diffuse frontal lobe epilepsies, and the temporal entorhinal cortical zones feed into the anterior temporal. Now, DBS initially was approved from epilepsy only for these patients, but we found, with collaboration with Dr. Richardson at Mass General, this is a slide from him, this is a derived map of pathways into the thalamus. So a lot of patients will come into the hospital and have electrodes deep into the thalamus. And here's a study that we did on these generalized bilateral cases. So I was part of this group. He was my resident. This is the neurosurgical team at the other hospital. So we have a collaboration with them. They're really just down the street. And we found that there's a huge reduction of seizure frequency just by putting these electrodes in and turning them on with these generalized malignant bilateral tonic-clonic seizures, of which we can't find a gene, for which there'd be no other cure because they've all failed medicines. So maybe we'll stop there for the time being. But here's someone that has dual systems. There's a cortical stimulation and bilateral DBS. I spent a lot of time trying to figure out what the biologic marker of her disease is. She has a genetic syndrome called Landau-Kleffner. When she goes to sleep, her dominant temporal lobe goes into status, so she lost acquired skills of language. And over her life, she's had a very sinister course. She's now starting to become somewhat functional and awake. And this is the targeting during her surgery. This is what the stimulator looks like in the skull. There's 2 of them. This is the most recent one. She already had a right temporal lobectomy done years ago at another hospital that figured, why not? But that's not what we advocate. We want to find the network, know the pathology, target the therapy to keep the patient intact as much as possible, give them a quality of life, give them hope if we can. There are a number of clinical trials being done on different types of seizures. Data set is huge. I know I'm going over time, but at our medical center, we have some very grateful patients. Here's one of our first temporal lobectomy who has her life back. This was a lady who was I think she was from Bosnia, who was terribly affected, ultimately able to have a baby. Sometimes these discharges in patients with dementia looks like Beethoven's Appassionata Sonata, which is why I juxtaposed it. Such a chaotic rhythm. And then here's our marathon runner. And one of our patients who was very grateful, they did a television show. I don't know if it'll project. No, it won't. I get a disclaimer, but he's on YouTube, very supportive of our epilepsy center. I don't think it's projecting, but that's okay. We'll see.
I never join a meeting without my AI meeting assistant to take notes.
Watch this.
Anyway, I know I became progressively a little more hurried and disorganized during my presentation to tell you all these things, and there's so much more to tell. But I'm very grateful to be here and to collaborate with you and to show you what we do in the clinical realm. We are very, very lucky to have patients that truly trust us to do this, because imagine, what would you do without this? And there's risks with surgery, and we have to follow when they want to not go beyond a certain point. We have to respect them and work with them, because they are the ones that poignantly assume the risks and burdens of the treatment. There's so much more to learn, so much more to do. Thank you for your attention. I welcome any questions and comments.
Thanks a lot, Professor Oster, for the talk. Any burning questions from the audience? Yes, please.
Thank you for the very illuminating and fascinating, fantastic talk. And so yeah, the old way of cutting out brain regions actually does work. I'm just trying to understand, because some of the very severe patients, they have these holes in their brain regions, and obviously that area is damaged and there's no more tissue. And I would imagine that over years that some of the seizures have transferred or affected many of the other regions, ipsilateral or the contralateral areas. Can you maybe comment a little bit on that also, which is once that once the epilepsy has developed into such a severe stage where there's a hole in that region, now presumably that region, now obviously that region is gone, and therefore why would that not stop seizures from happening?
Thank you for that excellent question. This is the frustration of many patients. They don't realize they signed up for a series of surgeries and a series of failed therapies many times. This is the hope of neuromodulation, is you don't have to cut anything. You can preserve the brain function, maybe treat it as we learn about the network, target it with these more targeted genetic or other therapies that will actually be more focused and work. Tuberous sclerosis, which is a genetic disease that has multiple tubers throughout the brain. And when I was in fellowship, we would go after the tuber or two that was causing the seizure discharge, only for a year later the patient to have another area in the network with a lowered threshold to resume the primary epileptic zone, and oh my, the patient's having seizures again. So some of the drugs that have come out, like everolimus and all these other targeted therapies in that group, they're only palliative at best too. This is where use of neuromodulation, where you don't do any cutting, you don't cause any lesions, you don't cause any new lesions, you don't cause new pathology, where you can maybe get control to the best effect you can. In our hands, 90% of these subclinical discharges go away. 56% of them have no seizures in that small set. I don't know if that's inflated or not. That's the spirit. I think we could use this in the eloquent zones, the language areas, the computational parts of the brain, and preserve the brain. Put this device on the cortical region and study the biology. Learn your point of what's going to happen distally in the network and beyond a certain time in the network to have epilepsy return is a real phenomenon, and the literature doesn't capture it well. Short-term outcomes for 1 or 2 years does not prove epilepsy surgery is effective. However, in mesial temporal sclerosis and certain ones that have lesionectomies that are effective and there's no other zone, that might be okay. So there are, cortical dysplasias, these abnormal dislamination of cortical. It's throughout the brain. You might find the subtle one that's the cause of the seizure, but you have to assume, like the tip of the iceberg, there's other smaller ones you can't identify. This is where neuromodulation might allow us to gain control of the currently active zone as we learn where the rest of them are and treat it surgically, focally with other targeted molecular therapies that will be more reliable and more durable. But this is exciting.
Please, one more question.
Okay. Dr. Oster, thank you for the talk. I'm an outsider, but the work that you do, you've shown is very meaningful, and I think very inspiring. Again, as an outsider, I don't know, so I asked this question. I think you showed about 3 types of brain stimulation.
Yeah.
So first, using the implant. Secondly, in the surgery, where you have 2 probes and pass a current.
Right.
And third, with those DBS, what do you call them? Like implanted probes, where you implant them in a surgery and then you can do stimulation. I was wondering what the differences are in those 3, and if they have the same effect, I suppose everybody would just do the RMS implant. But what?
It's an
what are the
excellent
differences?
question, and I'm so happy that you derived those 3 points from my talk. I worry that I talk from a super specialist, so it's not understandable by others, but you grasp the concept incredibly well. The different probes are designed to go where we think we need to anatomically be. So in these diffusely, poorly localizable networks where there really is no good, small enough cortical zone, we don't hope to cover every area of the cortex. We have to expose all that, put the patient at risk, have bilateral electrodes. A lot of patients have very bad post-op hemorrhages. So we use the deep probes into the different regions of the thalamus, depending on what address the seizures are happening at. And then we have to decide in a hypothesis, is it focal on one place, or is it regional in one place, or is it bilateral and spread out? The FDA only approves ultimately the implantation of 2 electrode arrays. So some of our patients we implant with multiple electrodes, but we only hook up 2 of them. It is our hope that over time, as we learn more about the pathology, that we could, when the battery has to be changed, it doesn't charge on a ring at Starbucks where you can charge your phone in the States. You have to actually have the skull itself, not the brain exposed. Take the computer out of the skull and change the generator. Could you hook up these other electrode arrays? So we have a bunch of patients that have multiple electrode arrays implanted, but we only use 2 because that's what the Food and Drug Administration allows. Over time, we might have a more broad and deep understanding of your question. Maybe if you stimulate for a while in one type of electrode, maybe you ultimately need another type later on, or maybe we don't know. No one's looked at it. These types of questions are really what's important. Asking the right question, testing a hypothesis, having the time to do the research to elucidate a longitudinal, meaningful understanding of the biology, rather than what's good at the time right now as in a sensational way, although this is somewhat sensational. So that was a very profound question.
Yes, last question.
Thank you so much. Thank you so much, Professor Oster, for the insightful talk. I just have a question, and the question is that it's quite known that the therapeutic efficacy of responsive neuromodulation or neurostimulation can be dependent on the stimulation parameter as well as the volume of tissue activated.
That's right.
But at the same time, activating a very large volume of tissue can also cause brain damage over time. So how do you make sure that you activate a minimal volume of tissue while also opting for an optimal therapeutic efficacy at the same time?
That is the basic safety question. Imagine how a patient feels, or the early patients felt, when we didn't know what was safe. Although from the 50s we knew that, 1950s, it was known that probably a temporal lobe could have 7 or 8 milliamps or microcoulombs of charge present before it would spread up the hemisphere and activate the motor areas, before you would feel it. So those general parameters we know. In the occipital lobe, you really only have a milliamp or 1 microcoulomb or 2 before you see these flashes of light. So the different brain regions depend. The insula, we have some patients, and that one I showed you with which area is driving them which, it ultimately turned out that the insula was being driven by the temporal lobe. So a half of a microcoulomb was all it took to treat that insula electrode, and now this patient's ready for a temporal lobectomy if they pass the water. Or, like your question, maybe they should wait and we should understand the network further. But the parameters, though, This is where the database of the 4,500 patients who have undergone this is so helpful, but it's also only a limited number of patients. We have to be very, very careful, which is why I don't want to go more than an incremental effect every few months, because we don't know. And this is what the risks of the FDA acknowledges and puts on this technology, which is why it wants us to lock it out after a certain amount of current during the day. I forget what that number is, and the number of stimulations. And this is why it's so incrementally hard to really know. But in that Norse case, that patient that came in that was going to die, that couldn't be extubated, we ramped up to the standard temporal lobe setting over a couple of weeks based on my own personal observation of how we had to reduce the frequency of discharges. I know patients can talk and interact when you have 2 hertz of discharges. 2 to 4 hertz is ictal continuum. Patients are beclouded. More than 4 hertz, they can't speak, they can't be awake. So I often target my therapy on these gross assumptions without really knowing. This is what's so humbling about the trust that each patient puts in us. We really don't want to do harm, but we're stuck because they have no other option. That's an excellent question, and this gets to the humanity of what we do. And we don't even know how we're affecting the biology. Dr. Hay.
Wonderful talk.
Thank you.
So, Professor Oster. My question is, after seeing so many patients and also seeing your modulation, some works and some possibly not work, so what are your opinion or comes out, what brain region is the most kind of correlate with the epilepsy?
This is a deeply profound question and a personal one, because I have patients now that have followed me almost 27 years, and I worry that an earlier version of myself did not analyze the data properly. Some of them I know there are multifocal areas. I believe we learn the most from our failures. It's poignant. They still trust me. But did an earlier version of myself make a mistake? Or did the biology change? And why? So my thought is to remain humble and really ally now with the neurobiologists, now with system biology, now with engineering, to use responsive neurostimulation as a temporary mechanism without cutting, without doing surgery, to get the network properly identified and to see if a more targeted approach that's meaningful will exist rather than cut. Although some patients need that. Some patients will respond to a surgical cure 2 to 5 years. Then the literature ends. But it's from our failures that we learn more than we know, and we have to be humble. We have to be honest with the patients. What happens to the network? We don't know. It's sensational that we have these patients running the marathon and doing all these things, but have we changed the biology enough? What's good enough? What requires to stay on medicine? So we've had patients, for example, we map out the epileptic zone, but it's near the leg area, and they want to have their leg strong enough, but we know there are discharges in that area that we don't touch, we don't cut. One such patient has been seizure-free since 2015, but I worry. I tell him every office visit, I don't know if 5 years from now, because I know I left brain region behind. You are cured now, you stay on one medicine. Will that become a focus? I don't know. I have another patient that we have these epilepsy conferences where everyone looks at the data we thought had right temporal lobe epilepsy, who now has left temporal lobe epilepsy. Did we miss neuroinflammatory cause? Did we mislocalize? 15% of mesial temporal sclerosis cases, even if they don't have a lesion, might be bilateral or might evolve to such. Which are the patients? Which are the cases? So we have to be very humble and very honest and very caring and support these patients when we ourselves don't really know 100% about the biology. This is why it's so imperative and crucial to ally with an academic system to study this, particularly on the resected tissue, if we can, in my opinion. Thank you.
So thank you very much for a very excellent and inspiring talk shown by the vibrant Q&A sections. So I hope you can, if you have more questions, please continue to talk to Professor Oster, and we will hopefully be able to initiate some meaningful discussions and collaborations with Professor Oster. I'm sure Professor He can share more about some of the exciting initiatives and plans that we are trying to pursue now. So with that, once again, thanks very much for your time and for your sharing.
Thank you. That was so much fun and such an opportunity and an honor. I am so grateful to you.